The next speaker, Dr. Madhu, he'll be speaking on Bowman's membrane transplant, bridging the gap in the management of keratoconus.
Very good evening to all of you. Thank you, sir, for making me part of this IC. Thank you, Srini, sir, for inviting me to this KSOS Golden Jubilee celebrations. So in the next few minutes, I'll share our experience with this Bowman's layer transplantation in the treatment of advanced keratoconus. So why Bowman's layer? So if you see the John Marshall's lecture, so he tells that you can consider Bowman layer as the tendon of the eye because they provide a good mechanical, biomechanical strength. So this is not something new. This has already been done by the Mellis group and they have already several publications. So how is exactly our technique different from theirs? Because if you see, this is what we are doing is not an isolated Bowman's layer transplant. We also try to harvest 70 to 100 microns of stroma along with the Bowman's layer. So this helps us increase the central corneal thickness, attaining more flattening, and this procedure has a relatively less learning curve, and to be precise, it should be called as the Bowman's layer stromal transplant. So if you see, the Mellis group themselves have stopped doing the isolated Bowman's layer. In the last World Cornea Congress, now they are putting 2 Bowman's layers as an overlay. So in India, myself and I think Dr. Vikas sir are doing this procedure, and both of us are using this stroma along with the Bowman's layer. So this is the video of the procedure. So I don't have access to a femtosecond machine, so all this thing is done manually only. So first I'll show you the donor preparation. After mounting the donor tissue onto the Barron's anterior chamber like you do a DSEC, you debride the epithelium and stain the Bowman's layer with help of blue, and it's usually restricted to the central 7.58 millimeters. Like you do a can opener, you just create a groove with a bent 26 gauge needle all around. And once you have a groove, then you have access to create a layer with help of your crescent blade. So once you get into that, then you can just expand that thing 360 degrees. And while you are expanding, it's important that your left hand creates a traction so that the plane in which the dissection happens is kept in a smoother plane and you don't have any interface issues later. So almost after completing 3/4 of this, you can just peel off the remaining thing. So that's the Bowman's layer with 70 to 100 microns of stroma. You can also use a guarded blade to determine the depth. So once this is done, again you refine it to the desired any size between 7 to 8. We usually take the 7.5. Initially we are using this 7 millimeters, but now routinely we use the 7.5 mm refine. And you can also nicely smoothen out the interface surface either with a diamond burr or a 15 number blade, and that's the donor ready for insertion. Coming to the recipient. So again you mark the central part of the cornea, and with help of your regular crescent, you can create a mid-lamellar pocket, and using the Summer-Bussack dissector that we use for DSEC, you can extend this pocket into the marked area. And once you create this mid-stromal pocket, make sure that you hydrate it and wash out all the blood that is there in the interface, and nicely hydrate it for the stromal implant to go inside. So this is like a regular SICS tunnel. It would not require a suturing post-operatively. This is the lens glide. Just place the Bowman's layer transplant. And you center it well and iron out the folds with help of a regular spatula. So that's the end of the surgery. And that is how post-operatively the transplant would look like. So these are some of the very first early cases that we did. So if you can see here, the pachymetry improves and also the cylindrical value reduces. And all these cases, vision also improves with contact lens. This particular case has a very dense scarring superior limb, case of VKC in a 16-year-old. In these cases also with apical scarring also we could attempt and do this technique. So these are all the results. So we have been doing this technique from June 2017 and so far we did 24 cases. The primary outcome of stabilization is possible in all the cases. So these cases are done in cases that are not suitable for cross-linking. At the same time, you don't want to go in for a corneal transplant. So these cases we can avoid the transplant, and all these cases because of flattening and better shape, these patients become tolerant to regular contact lens or scleral contact lens and they have an improved visual outcome. So the elevation maps also you can see they come down. These are the reduced higher order aberrations in the initial cases. We are doing the publication for all the 24 cases now. So combining with cross-linking, we try to do it in 3 cases. We always prefer to do it sequentially rather in a single sitting. We did it in 3 cases and very early experience of 6 to 8 months follow-up. This has also yielded good results. So take home is BLST is a novel technique that has a beneficial role in progressive and advanced keratoconus in candidates that are not suitable for cross-linking and too early for a graft. The primary outcome of stabilization can be achieved in all the cases. Secondary outcome of better contact lens tolerance and visual improvement also can be there. Improvement in pachymetry, unlike isolated Bowman's layer, makes it eligible for a cross-linking in future whenever required. Reduction in astigmatism and higher order aberrations gives them good quality vision. This procedure, when performed at an appropriate time, can reduce the need for a transplant. Thank you for your kind attention.
Thank you, Dr. Madhu. Our next speaker is Dr. Vinay. As he gets ready, Dr. Madhu can take few questions. Is it just a stabilization or you are getting some flattening also? You mentioned
flattening is definitely there, sir.
Okay.
And previously because of the bad cones, you can't fit the contact lenses and all in this. But once you have this 100 stroma in the central part, overall there is a good flattening and patients also improve with vision.
And you don't have any issues of interface haze or
no.
quality?
Actually, whatever 100 microns we are doing, sir, at the end of 6 months, it becomes compact. It's only hardly 60 microns that would be left.
But what is the depth at which you are going?
Mid-stroma, sir. Because all these corneas would be below 400.
You are using particular depth blades or?
Yeah, initially we used to do it with a guarded blade that we get for DSEC. Now we are doing with...
At what depth?
Usually it would be around 150 to 200. Okay. I would rather tell it is a mid-stromal thing where you have a better grip.
And once again on the case selection, your ideal case would be the one with the low pachy for...
Low pachy, not suitable for cross-linking.
But not as advanced as that for a DALC or something.
Yeah.
Okay. So JK sir, yeah. Any comments?
Stroma heals, sir. Anything you put in the stroma heals well.
You are telling there is no scar formation.
No scar.
No, is no scar. As he rightly telling, mother is no scar. Manual doing is we did initially. It's very tiring for surgeon. It's especially in thin corneas. So right now we adapted for femto because we bought it femto. Initial results are not good, so we abandoned after doing 10 cases. We started some 20 years back, 2004, 2003, like that. Then we learned, looking at back, that's what called research. You search again. What is research means? You search again where you went wrong. So we abandoned, then we started researching. Then it's a good technique. There are a few points we learned. I will tell in my presentation.